of Vero Strength Conditioning, and on behalf of Icaria and Vero Strength, welcome to Redefining Aging. We're good friends with Dr. Felice Haake and Felice Haake, as well as Dr. Vero Strength, and we talked about putting together a presentation about a free local talk to kind of cut through a lot of the noise out there. You hear, headlines all the time about health, and it can be really confusing. So we're hoping that we can kind of clear, some of that misinformation tonight, and we leave with some actionable steps to live longer, stronger, and with more vitality. So you're going to hear from Icaria first, from all three doctors, and you're going to hear everything from the current state of healthcare to insulin resistance to hormones and more. So I'll give you a brief bio of each speaker, and then we'll welcome Dr. Brett Haake to the stage. So Brett is a board-certified anesthesiologist and preventative medicine physician with a background in the U.S. Navy. His work focuses on longevity, metabolic health, hormone balance, and stress mitigation. All right, his boss, his wife, Dr. Felice Haake, is a board-certified osteopathic physician who specializes in family, bariatric, and functional medicine. She's a diplomat of the American Board of Obesity Medicine, helping patients reach optimal health through a holistic long-term approach. And I've seen many of these success stories that have worked with Felice before. And finally, Dr. Vero Strength, he's a Vero Beach native, and he has over 15 years in emergency medicine. At Icaria, he focuses on what he calls hyperprevention, getting ahead of disease by addressing root causes before they start. All right, let's welcome to the stage Dr. Felice Haake.
Thank you so much, Wendy, and thank you everybody for being here. She's, the introduction was excellent. I am an anesthesiologist. I want to start off tonight and just talk about a couple of things like this. I want to point out a couple of things, and I want everybody to understand I'm not throwing stones. I've been a cardiac anesthesiologist for close to 20 years, and so what that means is I've taken sick vascular patients to the OR that essentially intervene at end-stage disease, flowing through the asteroid field, if you will, and then drop those patients off in the ICU. I have a dinner with my other anesthesiologist colleagues, cardiothoracic surgeons, vascular surgeons. We all kind of sit back and agree we don't want to be that patient. And so one thing that's led me to think about is what are the things that we can do to teach patients and not get to that point. And I think that the development of vascular plaque is one of the things that's very poorly understood, both in the civilian world and in the conventional world. I think with that, the understanding of cholesterol and the way it affects your physiology and pathophysiology is also misunderstood. So I just wanted to talk first of all about a couple of stats. Okay, is that better? Sorry. We in this country, we spend $4.3 trillion a year on healthcare, okay? So that's 20% of our GDP, okay? And so we spend more on healthcare than any other industrialized nation. And for that, we have, these slides are pretty conservative, but obesity affects 4 out of every 10 Americans. Insulin resistance affects 4 out of every 10 Americans. The number is probably closer to 5 out of 10, okay? And so with that, we spend $4.3 trillion on healthcare, and with that, we are last in all industrialized nations in life expectancy at birth. Okay, so we spend more and we're last. So there's obviously a disconnect, and I think one of the things, I'm not here to throw stones. All of my colleagues work really hard. I don't know a physician who doesn't work really hard. I don't know a nurse who doesn't work really hard. I don't know a tech who doesn't work really hard. So everybody's working really hard, but there's really no economic incentive at all in the United States to actually prevent disease. So next slide. So again, last in all industrialized nations, in spite of the fact that we're, quote, a free market system. So next slide. So one of the things that I really like to talk about and really kind of get people to understand tonight is what insulin resistance is and how to understand it, how to diagnose it, and then maybe some steps that you can do to actually try to reverse it. So I put this slide up here because I would say that most people in conventional medicine understand insulin resistance to mean it's what you get before you develop type 2 diabetes. While that's true, I think that it limits the understanding of what it actually really is. And so stated simply, resistance to the hormone insulin is just the cell's inappropriate response to insulin signaling. And when that happens, okay, it literally affects every organ system in the body. So insulin resistance is upstream from about 95% of all non-communicable diseases in the United States. For instance, Alzheimer's disease is essentially advanced insulin resistance of the brain. Fatty liver is insulin resistance of the liver. Endothelial cell dysfunction is insulin resistance of the vascular lining. Sexual dysfunction or erectile dysfunction is insulin resistance of the endothelial cells. Over 50% of everybody in this country that gets diagnosed with type 2 diabetes already has plaque in their coronary. So it makes no sense if we're interested in prevention to wait for the A1C and the blood glucose to rise before we're actually addressing metabolic dysfunction. It makes far more sense to actually measure insulin resistance or metabolic function, and if you're dysfunctional, actually take steps to reverse the dysfunction. The byproduct of that is you'll lose weight and feel better. The advantage to the healthcare practitioner is we're actually going to prevent disease and make you more functional. Okay? So just to give you an example, one thing Wendy didn't mention is on Sunday I'm actually taking a board in lipidology, which is the advanced study of cholesterol. I got that board because I feel like one of the litmus tests when we sit down with the patients is any patient is like they're going to judge us on our answers. Do you like statin drugs, right? And my answer is always, it depends. So if you're practicing precision medicine, it depends. And it's one of the things that's so much more nuanced and technical that I think even most conventional doctors give credit to. So I wanted to use this slide. I know it's a busy slide, and I apologize. But basically, this is the development of vascular plaque over decades, okay? So what is necessary for a plaque to develop over decades? Mind you, if this process, here's the plaque over here, this is the inside of the blood vessel, this is what's called the vascular intima, okay? If this process develops in the heart, we say you're at risk for a heart attack. If this process develops in the brain, we say you're at risk for a stroke. If it develops in sexual organs, we say you have erectile dysfunction. If it develops in the peripheral vasculature, we say you have peripheral vascular disease. The process is the same everywhere. And so instead of waiting for someone to develop plaque, we need to think about how do we prevent it. The problem, I think, or one of the shortcomings in conventional medicine is we have this tendency to only look at cholesterol, okay? And so I just want to point out, here's LDL, okay? That's what's referred to as, quote, when you go to the doctor, bad cholesterol, okay? So what is necessary for this plaque to develop over decades is this bad cholesterol has to move into the vascular intima. It becomes oxidized, leads to rusts, and then over time there's an inflammatory reaction that leads to the development of these foam cells, and then ultimately these foam cells coalesce and form plaque. So there is a bad cholesterol component to the development of plaque, but what is also necessary is inflammation, oxidative damage, and vascular immune dysfunction. If you are not a smoker, okay, the number one driver of inflammation, vascular immune dysfunction, and oxidative damage is insulin resistance. So again, this is why over 50% of everybody that gets diagnosed with type 2 diabetes already has plaque in their coronaries. It is also why, while I would say it's irrelevant to look at a fasting glucose and an A1C, we also need to be measuring insulin resistance when a patient comes into the clinic. And I think that's central to understanding prevention. Okay, next slide. I included this article in here because I came across this piece. This is what's called a Cochrane analysis. And what they did with the article is they looked at 50 different studies going all the way back to the early 90s. And they looked at insulin resistance and erectile dysfunction. And the conclusions of the study, after looking at 50 different studies over the last 30 years, is if you're a primary care doctor or a urologist and someone has erectile dysfunction or sexual dysfunction, the first thing that you have to do is address the insulin resistance and reverse it, okay? Next slide. Insulin resistance and Alzheimer's disease. This is a really complicated topic, but the bottom line is that when your body develops resistance to insulin, insulin has a tougher time removing amyloid beta plaques that were called tau proteins from the brain. And those are the two things that we said are pathognomonic for the development of Alzheimer's. So insulin is central to helping remove those plaques from the brain. When your brain develops insulin resistance, you're not as efficient at doing that. And so advanced insulin resistance in the brain is essential with Alzheimer's disease. Now it's much more complicated than what I just said, but the point is that there's insulin resistance to the brain is Alzheimer's. That's like, so if anybody's interested, remember this guy's name right here because he's got a lot of different podcasts and lectures. His name is Thomas Seyfried. He's a biochemist from Boston College. What he's done is he's tacked on the work of a guy by the name of Warburg, who is a biochemist from Germany in the 1930s. Warburg was the guy that figured out that cancer gets its energy by converting glucose into lactate. Okay, now Warburg did this without any knowledge of cellular biology because they did not have the electron microscope. What Seyfried has done, and he's demonstrated this over and over and over again, is that cancer is actually, what he's demonstrated over and over is cancer is actually a metabolic disease and not a disease in the DNA. So what he's done is he takes the mitochondria, and this is the part of the cell that is intimately related to either good metabolic function or bad metabolic function. So the mitochondria is the part of the cell that makes energy. If you have good metabolic function, the mitochondria works well. If you've got bad metabolic function, the mitochondria doesn't work well. What Seyfried has done over and over again is he takes the mitochondria from a cancer cell, puts it into a normal cell, and the normal cell develops cancer. He then takes the DNA from a cancer cell, puts it into a normal cell, and the normal cell stays, with normal functioning mitochondria, the normal cell stays normal. So this is so the corollary to this is what he then does with cancer patients is puts them on a low inflammation, low insulin recruiting diet. He does keto diet, but any low inflammation, low insulin recruiting diet, and what happens is he does this does it adjuvant or with chemotherapy, and he's got all kinds of cases where the cancer essentially goes away. So the corollary is that if this is the way that you should be eating when you've got cancer, why don't we just eat like this all the time, right? So next slide. So I just included these because there's a lot of, we do a lot of peptide therapy in our clinic, and a lot of our peptide therapy is designed to upregulate mitochondrial function, okay? We do what's called, I don't know if anybody's heard of RedBed. So we do photobiomodulation therapy. We got medical grade, and what that does is it works over here, and it just simply allows oxygen to take its appropriate place at the level of the mitochondria. Methylene blue is kind of interesting because as a cardiac anesthesiologist, occasionally you get a patient with what's called endocarditis. If you use IV drugs for long enough, you'll develop an infection in your bloodstream that packs the valves of your heart. And so these patients end up in the ICU, they get fluid in their lungs, and so they need to have emergency surgery. What happens with these patients is they have circulating things that attack the mitochondria. So what happens is you can't get them off cardiopulmonary, you can't get them off the heart-lung machine. So what we would do with these patients is we put them on IV methylene blue, and they'd fly off the heart-lung machine. So when I started reading about methylene blues, mostly the Chinese, and now we're starting to study more and more in the United States to improve cognition, the disease orally, I was kind of intrigued by it, and in fact, there's a lot of good data that suggests using methylene blue will actually help with your cognition, okay? Then of course, NAD is something that's pretty popular, there's a lot to see here in the body. So this, we focus on mitochondrial, next slide. And then testosterone. I know that testosterone is kind of the Wild West in Florida, okay? You see a lot of testosterone clinics. There's a lot of what I think is probably an appropriate use of testosterone. But I think that the take-home point is that there's a couple of things actually. One is that men are walking around with lower testosterone than our grandparents or our great-grandparents. Nobody really understands why. I think if you factor in the fact that everyone's walking around with metabolic syndrome, that we're explaining some of it. Is it the food that we've got? Is it the fact that we're not invading Iwo Jima or sitting at a computer? I don't know. We walk around with lower testosterone. When you replace testosterone, there's a lot of different ways to bring testosterone into the youthful range. It's not just testosterone replacement therapy, but when you replace testosterone, your cognition improves, your energy improves, your libido improves, your sleep improves, your mood improves. All those lifestyle factors improve, but I think what most people don't understand is that testosterone is actually a metabolic hormone. And so most of your good data with testosterone deals in the realm of patients with either insulin resistance or type 2 diabetes. So what testosterone will do, when you bring it into the youthful range, is it'll lower your fasting blood sugar, it'll lower your hemoglobin A1C, it'll lower your fasting insulin, and makes the fat cells that surround your organs in your abdomen more sensitive to insulin and less inflamed, which is what you want. Okay, that's fine. And then I just included this slide because in addition to insulin resistance, we do what's called an advanced cardio IQ cholesterol panel. And a lot of these different markers that we test for are reflective of various steps in the plaque buildup process, all of which are related to insulin resistance, and kind of gives you a complete picture of how you actually want to intervene in order to prevent or in fact reverse some of the vascular plaque. Okay. And if anybody has any questions about that, we can talk after the presentation. That's fine. So just to kind of take our home that our clinic, there's healthcare everywhere in the United States. We spend a lot of money on it, and yet we have to be honest about where we're at. We're last in all industrialized nations in life expectancy at work. And so, we think about prevention and functionality, and then we think about lifespan, but not only lifespan, we think about health span. So health span is the length of life that you live without any significant comorbidity. One of the things I ask patients when we sit down is I'll say, what is it that you like to do? And they may say, well, I like to surf, or I like to fish, or I like to go on walks with my spouse. Whatever it is that they like to do, I say, well, my goal for you is that if you live to be 100 years old, that you do that in a functional way when you're 100 years old. And the science is there to make that happen. So I don't dictate when the good Lord calls you home. What I can do if I'm doing my job is increase your chances of being functional all the way until that day comes. So we throw just prevention functionality in the next slide. And then longevity and health span. And I always say, we do all these really cool things, but if you think about any, like beautiful throne or whatever, you go to Europe and you see some kind of king's throne, like all the gold and everything. If 84 points on that throne aren't working, the base, then that throne becomes completely useless. And for a human being, it's diet, exercise, sleep, and stress. That's the reason. So all these things are related ultimately to diet, exercise, sleep, and stress, and then we build off of that foundation with all kind of the fun things that we do. So that's it for me. And then my wife is going to talk about women's health conditioning. Thank you.
Hi, thank you so much, everyone. He's a tough act to follow for sure. Famous box, so yeah. So my name is Dr. Felice Haake, and I'm board certified family practitioner. As Wendy already said, I also have a board certification in obesity medicine. And I'm going to be talking about menopausal hormone replacement and where we are now. And I thought to myself, okay, I'm going to do a math trick basically. I have to have about 5 or 6 slides on a topic that entire books are written on. My 2-hour podcasts are spent on. So what I thought was, well, what's my objective? And what do I hear mostly from my patients when they come in? Not all, but many of them are, hormones are bad, or my doctor told me hormones are bad. And I know where it stems from. It stems from a study from the late 90s into the early 2000s called the Women's Health Initiative. Many of you may not know the name of that study, but you've heard that hormones are bad before, for sure. So I'm going to talk about some of the flaws in that study, some of the myths, and hopefully dispel those myths. And my hope is that you guys will go on with some knowledge, maybe more knowledge in this subject, and then tell other people. But we really have to, at this point, we're 25 years past the study, we have to debunk this at this point. Okay, study says owning a dog makes you 10 years younger. My first thought was to rescue 2 more, but I don't want to go through menopause. Okay, so, and the men in the room might think that this doesn't pertain to them, but if there is a female in your life of menopausal age, trust me, this pertains to you, okay? Your life will be much happier if she is happy, you know that. So next slide. Okay, so the long-standing debate, myths debunked, a review of the Women's Health Initiative. So this was a landmark study, okay, multi-faceted study. So it had a wide endpoint. It wasn't just about hormones, okay, but it was the largest conducted randomized controlled trial on hormones. And it started in kind of the mid-90s, early 90s, into early 2000s. It was cut short. It was alarmingly cut short, which we're going to talk about, okay? And so the goal of the study, oh, by the way, it was, and it may still be one of the most expensive studies ever conducted, is $1 billion. So the goal was to test the index of postmenopausal hormone replacement therapy on heart risk, osteoporotic fractures, and breast cancer. A study it was very powered. It had a large amount of women in it. 68,000 women were randomly assigned to different treatment groups, okay? So they had a hormone treatment, a diet modification, and calcium vitamin D. And for the purposes of our talk, we're just going to talk about the hormone replacement. And within that group, there were 2 arms of the study. This is really important to know. It may seem too detailed, but it's really important to understand where these flaws came from. So there was a progestin estrogen arm. I say progestin, not progesterone. I'll explain that difference in a second. And there was an estrogen-only arm, and that was the amount of people in each arm. The estrogen-only arm, those women did not have uteruses, okay, because the mainstay of treatment, and it is still today, is you don't need to give progesterone to a woman who doesn't have a uterus. So that was the difference in the 2 arms and why they had those 2 different arms. And basically the study was abruptly cut short because they saw, and I'll quote, a statistically significant increase in breast cancer, heart attacks, strokes, and blood clots. And overnight, there was a media frenzy. Some of you may remember this. I was just kind of entering medical school around this time, and the presses were alerted, and the public were alerted that hormones are bad, they cause breast cancer. And overnight, women stopped their hormones, doctors stopped prescribing. And what's really interesting about this part is that the actual data was not published yet. It was unprecedented. They never had done this historically that I know of, where you basically alert the public of a finding and there's no published data. So imagine you're a 2002 doctor practicing medicine, prescribing hormones, which you thought you were doing the right thing. This comes out, your patients are calling, freaking out. You don't even have an actual study to read. And in medicine, one of the things we really have to learn, and I'm still learning, it's very difficult, is how to read studies and how to know what's a good study. I have patients on a daily basis, melatonin causes cancer, this and that. What's the study? Bring it to me, let me read it. I never discount what they're saying, but you have to really understand these studies. Next, please. Okay, so the flaws of the studies and misconceptions, and I'm really just pulling out the big points. You really can read about this, you can listen to podcasts about this, it's really remarkably interesting. It's almost like a Real Housewives episode, I swear. It was controversy, somewhere. So the first part that was flawed was the population of the people chosen in the study, or the women chosen, okay? So there was an age issue and a timing issue. The age of the participants were over 60 on average, okay? So the 50 to 79, with the average woman 63 years old. It's not the typical age that you start hormones. So it doesn't really represent the typical hormone population of initiation of hormones. The second was most of them were 10 years past menopause. We really try not to start hormones 10 years past menopause. There's some risk to that. So, and we can talk about that later, definitely on questioning as well. And then the actual population, when you looked at them, 70% of them were overweight and obese. 50% of them smoked. A large percentage of them were on a blood pressure medication called hypertension. So this was a sicker population. If you're studying cardiovascular endpoints, they're already set up for cardiovascular risk. So now we're blaming the hormone towards. It wasn't the best population to choose. The type of hormone replacement therapy used has also been questioned and scrutinized, and there's definitely still some debate on this. The first one is CEE, which is conjugated equine estrogen. Essentially, you've heard of it, Premarin, comes from a pregnant mare's urine, okay? So of course. And although there's a lot of docs out there who say there's really nothing wrong with this one, it is relatively natural. However, it was in pill form. And really the mainstay now is to give estrogen through the skin. It's safer. It does go through the digestive tract and increase clotting factors. And then the second one is MPA, medroxyprogesterone acetate, which is a progestin. Progestin, you have to know, you cannot call it progesterone. Progesterone is the natural hormone that you have in your body, and they have them commercially available, progesterone, natural progesterone. But progestin is a synthetic. Okay, so it's not exactly, your body doesn't see it as self, so remember that. So there's definitely a question on the type of hormones they use, and also the route, the pill form estrogen. The data, when the data came out, when they finally published it, it was published in JAMA, the data was presented as relative risk, and this is really important. Relative risk compares two groups versus absolute risk, which looks at true numbers, okay? The relative risk was presented as 26% of increased risk of breast cancer. Would any of you take that chance, 26%, 1 in 4? No way, okay? But when you looked at the actual absolute risk, okay, and by the way, this is only in the arm of NPA and CEE, not the estrogen-only arm, okay? So make sure you know that. The absolute risk, when they looked at it, it was 0.9 women in 1,000 that had an increased risk of breast cancer. That is less than 1%, okay? So when drug reps come, I know there's practitioners in the audience, they know what I'm talking about, and they're wonderful, they're showing us their data, and they say, this reduces the risk of this. I would say, what's the absolute risk? A lot of friends show the relative risk, it skews it. So you really do want to know the real numbers. And then there were statistical errors that were made, okay? If you look at the actual paper, it wasn't, the actual increased risk of breast cancer wasn't even statistically significant. And it's cited in the paper. They say did not almost reach statistical significance. And in medicine, again, the practitioners in the audience will agree, we don't really change interventions based on non-statistically significant evidence. We need statistically significant evidence, and we need it to be reproducible. So that was a problem. There was also no subgroup analysis. How many of these women had been on hormone therapy before? How many had a family history of breast cancer? What was their ethnicity? What was their age? And there was later studies, this one in particular, 2006, Anderson et al., where they looked at these subgroups and they saw no statistically increased significance of breast cancer once they pulled out and extrapolated the subgroups, okay? So these are important things that, by the way, you never learned this. The media never told you. Positive stuff doesn't really sell. And then the estrogen-only arm, which at the time this information came out and the media was, presenting it to the population, the estrogen-only arm of this study showing decreased risk of breast cancer, about 21%, not mentioned at all, not mentioned one bit. So what's that about? And then impact on medical education. I can speak for myself. I could probably speak for Graves. I could probably speak for Brett. We weren't trained on this. Not as like we bought into it as well. It's that, and that's it. And when patients would come to me and say, "Hey, I really am interested in possibly starting this," or my other doctor did it, I'd say, "Nah, you don't need it," or I don't think it's good for you. I didn't really know, and I'm kind of embarrassed to admit that, but it's true. And so all my knowledge on this had to come from, studies on my own, essentially. And then there's been multitude of studies since the Women's Health Initiative. There's been extension studies to the Women's Health Initiative where they really looked back and pulled out data, and they're not finding this. So if anything, they're not always finding a decreased risk, but they're finding equivocal risk, meaning no increase, no decrease, just neutral. So there's a lot of data out there, and no increased mortality. That's really, really important. Next slide. Okay, so now you know a little bit of the flaws, and hopefully I dispelled some of those myths. There's myriad of symptoms that are alleviated by hormone replacement therapy. I can speak personally on it. I'm through it. And I had all of this, joint pain, hot flashes, you go hot, then you go freezing cold, bloating, fatigue, difficulty concentrating. Everyone thinks you're crazy who's around you. And literally, you replace these hormones, and it's gone within weeks, all of it. I really can testify to that. For most women, sometimes we have to adjust the hormones to we get enough care. Okay, so what do we know now? What are some of the benefits? And, we talk about the risk of taking something. We need to talk about the risk of not taking something. By the way, I don't work for the hormone drug companies at all, but we do need to think about that. There's so many tremendous benefits to hormone replacement therapy for the right women, and I know it's not right for all women. So relief from vasomotor symptoms, that's what the FDA has approved it for. That's, your hot flashes. And other menopausal symptoms like the joint pains, the fatigue, the cognitive, all of that. But there's also decreased risk of osteoporosis and fractures. This is so undervalued and almost never spoken of. The risk of an osteoporotic fracture to a woman over 70 actually is higher than risk of breast cancer. And dying within 1 year of that fracture. So we almost act like osteoporosis is nothing. It's really a problem. There is no better treatment for it than estrogen. Bisphosphonates are a close second, believe it or not, but they have side effects, unfortunately, and you can't be on them forever. So nothing's better than estrogen for that. Now, decreased risk of breast cancer. There are a multitude of studies that show that, and you saw it in the estrogen-only arm. There was a decreased risk. And that decreased risk of metabolic syndrome, Dr. Brett talked so eloquently on insulin resistance. That's essentially what I'm talking about. How many women, when they get close to menopause or through menopause, they say, I don't know where all this fat came from, or my belly fat, or I look, like I'm losing my waist. That's classic for metabolic syndrome. And that estrogen is very metabolically active. It really helps you lose fat and build muscle. When I started estrogen, my muscle was going down on the in-body scale. I was like, what is going on? Working out with Zach or lifting heavy. I couldn't do anything. As soon as I started, it started coming right back up. So it does have a metabolic advantage. And then decreased risk of heart attacks and strokes. Heart attacks being the number one killer of both men and women in the United States of America. And it's absolutely preventable. It really is. I mean, there's definitely some genetics, but it's absolutely preventable, and it helps there too. And then decreased risk of Alzheimer's and other disorders, cognitive decline. The Alzheimer's, for every one woman over the age of 60 who gets breast cancer, 2 Alzheimer's. Okay, so it's actually double. And Alzheimer's is an interesting disease in that it has a gender discordance, twice the amount of women than men. Okay, and they're still really trying to understand that, but the difference between men and women really is we go through an abrupt drop in hormones. They do not. They go through a gradual decline. So there's a lot of question about that. So and then there's some aesthetic benefits like acne skin, hair, all of that, but that's just an acne. I think that is linked. So again, that's a lot to pack into about 5 or 6 slides. I love this book. Brown Blooming, he's an oncologist, he wrote it. Brett and I really try to tell most of our patients he can read it. It's written for lay people, so you don't have to be a doctor to understand it. It is so well written, and he's excellent. And if you don't have time to read it, listen to one of his podcasts. Peter Attia did a great podcast and just recently listened to it and learned so much more. So there's information out there, and again, my goal is just for him to supply you with that information, and you guys to possibly maybe elaborate and learn more, gather more wisdom, and then share with other people what you learned. That's really what's most important to me.
Okay.
Hey, good evening. I'm Dr. Grace Romain, board certified emergency medicine. Some of you guys might be like, what does emergency medicine have to do with functional medicine and concierge medicine? Well, spending the last 15 years in the ER seeing patients roughly every 5 minutes to get them in and out, and sending a lot of them to the ICU or the OR with Dr. Haake there, it just got to be a little much in terms of not being able to spend this quality time with patients, just setting them on to the next treatment, that, it becomes a quick triage process. I was really losing faith in our system and just wanted to get back to the roots of what we were trained to do as physicians. And so as an osteopathic physician, sometimes you'll see behind credentials MD or DO. What does DO stand for? Doctor of Osteopathic Medicine. What does that mean? Basically, we are trained the exact same way as our allopathic colleagues, except for several hours of musculoskeletal medicine each week throughout our 4 years. And so what is that? It's what they call osteopathic manipulative medicine. That's where I come in to the practice, along with the concierge, along with the hormone replacement and everything else you've heard there. We talk about health span, we talk about lifespan. I want to talk about motion span and keeping you functional for what you're going to do. And so osteopathic manipulative medicine, we align your body, you set your nervous system, recharge your day. So basically, I'm working with one of the largest organs and systems in the body, that's your musculoskeletal system. If your joints are sore, if your back is sore, if your neck hurts, you're having headaches, you're not having a good day, you're not able to get to the gym, you're probably not sleeping well, you've got a lot of stress on you, and so you're eating that ice cream at 12 o'clock at night. So my goal is to keep that body in line. So small adjustments make big impacts. Structure drives function. So in the late 1800s, A.T. Stokes, the founder of osteopathy, said, if we can keep the body in function, we can keep it aligned. The body has the innate ability to heal itself. The way we describe it in our notes and stuff here, it's called somatic dysfunction. We're looking for those tight muscles in your spine. We're looking for maybe your spine is just out of alignment. Many of you probably had chiropractic medicine or treatments in the past, going in the whack and the crack, so to speak, where you hear the loud pop. What is that pop actually really doing? We're trying to adjust the spine to get it back in realignment. We're trying to adjust your sacrum or your pelvis, different parts of your musculoskeletal system back in alignment so that you can function, so that you can play pickleball, play tennis, play golf, do the things you love to do and stay active, which is our goal. Like Brett said, one of the main things we look at is exercise and getting back out and doing safely. Yeah, next slide. So OMT helps your body move how it was meant to, fluid, free, and balanced. And some of the things that we look to do, restore joint soft tissue motion. What does that do? Increase better circulation, increase the lymphatic flow, and oxygen delivery. Modulates your autonomics, really calms that overactive fight or flight system. Reduce myofascial tension and nociceptive drive. Less guarding, less pain, so that you're more functional, you can live that life you want to live. And improve proprioception and movement patterns, better posture performance. Things that the next team coming up, Rob and Wendy, will go over a lot in the gym, is balance, right, and form and function. Dr. Felice mentioned osteoporosis. As we age in our bones, we don't want to fall. We don't want to be on the ground. I remember bringing home my young son to my grandparents' house, and she was in her mid-80s. She was able to get down onto the floor, play with him, pick him up on her bone, and that's where I want to be when I'm in my 80s, form and function. And so, those are things that, we can help you restore there at our facility. These are just some of the modalities. I'm not going to bore you with every single one of them, but it's not just one treatment, one size fits all type of treatments. Everybody's ailments, everybody's different soreness or back pain or neck pain or whatever it is you have going on may require different modalities. Younger people may, be better for what they call the HVLA or hearing apnea crack, and the elderly patients may not be able to just, handle that, for risk of causing a fracture or something based on, their bone density and stuff. So these are just all the different modalities that are exposed, that I have to be able to treat the body, treat the musculoskeletal system. Really slow. So our treatment goals: less pain, stiffness, neck, back, headaches, arthritis, improved mobility and posture, breathing mechanics and energy, faster recovery from strains and sprains, and get the best we can, medication sparing when appropriate.
As much.
All right, guys, so let's talk about strength training, my favorite subject. Me, as well as my husband Rob and our staff, we've got some staff members, actually got a lot of members here. I could throw a rock and hit their members. We think that strength training is one of the most powerful tools that we have for anti-aging. And, I think a lot of people, actually, that's why I posed this question: what is the best anti-aging drug? Wasn't a drug at all. And I think a lot of people hesitate to strength train for one of two reasons, or maybe both. One is they're confused. Their doctor told them to strength train, or they read an article, but they don't know what it looks like, where to start. They might join a gym and walk around and see all these machines and not know what the hell's going on. Or they're intimidated. And we hear that every day. It's scary for someone to walk into the gym. They feel like maybe they're going to be judged or looked at. And that gym intimidation is real, and it's normal, and we hear it all the time. So, just want to put that out there. As I go through these slides, I want you to pay attention to the photos on each one. I've chosen current members of our gym to kind of highlight on each slide, and I haven't chosen anyone that's under the age of 50 years old. So check them out. I hope they inspire you as much as they inspire us on a daily basis.
Right.
I'll say, so first we're going to talk about the problem, kind of like the problem with aging if you're not strength trained.
Good.
So, sobering statistics. Adults lose 3 to 8% of their muscle mass per decade after the age of 30. So by age 80, the average person who hasn't strength trained has lost about half of their muscle mass. So imagine if you never strength trained, and so at 30 you're kind of weak. By the time you're 80, it could be pretty detrimental to your lifestyle. Strength and power decline even faster. So that's at about 3% loss per year. 1 in 2 women, so 50%, 1 in 4 men, 25%, I'm a mathematician, over the age of 50 will break a bone due to osteoporosis. Unfortunately, I'm sure everybody's here, I've known someone who's taken a bad fall and had at least a fracture, if not breaking something. Now, even worse is that after a hip fracture, 20 to 30% of those people don't recover. They actually die within a year, and then many don't regain independence. So they're living with assistance. They have nurses, their spouses helping them. They're not able to live their life like they want to. And then sadly, only 6.8% of US adults aged 50 and up get the recommended amount of strength and aerobic exercise per week. And we live in a really, I'd say, pretty active community. We've got a lot of pickleball players, tennis players, golfers, and that's all awesome. But I think the missing piece in a lot of people's lives is that strength training piece. So hopefully today we're going to convince you why you should be doing that. All right, so the question to ask yourself today is, what good is it to live longer if you can't live well? And that's that notion of lifespan over health span. So lifespan is the number of years you're living, but health span is the number of years you're living them well and you're able to do what you want to. All right, so here's the prescription. All right, today we're going to focus on exercise, namely strength training, because we're really passionate about it. We're experts in that. I do have to say that more than exercise goes into living well. I'm sure all of you guys have read or seen documentaries on the blue zones, and nutrition is important, and community is really important, sleep, and a lot of things that the docs here talked about. But for the purposes of tonight's presentation, we're going to go into strength training and what that looks like and why. All right, this is a little bit of repetition from previous slides, but I like to see this visual. In the blue line, you have someone who strength trains. The red line is someone who doesn't. Along the bottom, we have decades starting at age 30 to 90, and then relative strength on the vertical axis. So, it's showing that the untrained individuals, so the red line, you're losing that 3 to 8% of muscle mass per decade after 30. But what's really troubling is after the age of 60, that rate actually accelerates to 15% more. Now, I'm sure there's a lot of different factors that go into it. People tend to be a little more sedentary, they're not working as much, things like that, but this kind of really takes a nosedive. But in that trained individual, so say you, in a perfect world, start strength training in your 30s, you can maintain peak strength of 80 to 90% into your 60s. And then even into your 70s and 80s, 60 to 75% strength. So in a perfect world, we're all starting as we're young, we're maintaining it through your life. But again, it's never too late to start. We've seen a lot of people come in, in their 70s, never have strength trained before, and seen a lot of benefit from that. All right, so the point is, you can do something about it. Strength training is the most effective tool we have to reverse sarcopenia, which is muscle loss, protect bone, we all know how important bone density is, and live optimally. So you're chasing around your grandkids, you're going on vacation, hiking around Italy or mountains or whatever you want to do. In just 2 to 3 days a week of strength training, significantly improves muscle mass, insulin sensitivity, and fall risk, even if you're in your 80s. Now, studies are showing 2 to 3 days a week, and that is optimal. But I have to say, we have seen improvements in people in just 1 day a week. And when you're taking on something new like this, and if it's a little bit overwhelming and you don't have a habit, we always say start small. Start with 1 day a week, make it a habit, and then build from there. So if you don't feel that you can commit 2 to 3 days a week, 1 is very enough. All right, so now I'm going to go over some of the benefits of strength training as it relates to aging. So it's a hormone optimizer. It signals short-term increases in testosterone and growth hormone. And as you learned from the previous presentation, it's super important to have enough testosterone. It supports muscle growth and motivation and drive. So as Brett's his graphic with like the man boobs and all the other stuff, showed up there, your libido goes down, your mood changes. So testosterone can help improve that. Growth hormone helps repair tissues, and strength training actually lowers cortisol. So cortisol is your stress hormone, and if it's too elevated too often, you have chronic stress, inflammation, and strength training can help balance that. And lastly, it enhances sleep and melatonin rhythm. So everybody needs a good night's sleep. We all know the benefits of sleep. So strength training isn't just building muscle; it's actually sending different signals to optimize your hormones. All right, strength training and insulin resistance. So we learned a lot about this in the last presentation. But what you want to do, you want to think about muscle as glucose sink, and what it means is, what I mean by that is it's a sponge for glucose. So you eat something, glucose enters your bloodstream, and if your muscles are healthy and active, then it uses it for energy right away, or it stores it for energy later. Now, the more lean muscle mass you have, the more places you have to store that, so it's not just spiked. So that means lower blood sugar levels, better insulin sensitivity, and less fat storage. Felice talked about kind of gaining weight in your middle. A lot of times that is insulin sensitivity, the resistance side. All right, strength training and cognition, so the brain. I highlighted this study in JAMA that looked at older women who strength trained twice a week. And they reported improvements in memory and attention. And it wasn't just kind of, anecdotal or self-reporting. Brain scans actually showed a difference. And strength training is now being advised as a first-line treatment for depression. I've been seeing this, which is awesome. I've had some clients come in and say, my therapist told me I need to get to the gym. And I think that's awesome to get, that doctors are starting to do this now. But this tells us something powerful. It tells us that we're not only building muscle, we're also rewiring the brain. All right, strength training and bone density. Super important. So after the age of 40, the sedentary individual loses about 1% of bone per year. Now, 1% doesn't sound like a lot, but imagine now over 10 years, 20 years, it becomes very significant. That's why we see osteoporosis, why we see fractures. And again, I go back to that, a lot of people here are active and they're doing, they're walking, which is awesome, or they're playing tennis, or they're playing pickleball, but that there's nothing better than strength training to build bone. So even if you are to the point where your bone scans are not looking good, you can reverse that because bone is living tissue. When you add load and strength train, the pull of the muscle on the bone, it will stimulate osteoblasts. Think of these as the construction crew of your skeleton, and they actually lay down new bone tissue. So you're not only building muscle again, you're telling your body to build bone. All right, fat loss and body composition. I'd say most people when they come to the gym, we have a little consultation with them first, go over goals, and it's always, I want to lose fat, or I want to get stronger, or a combination of both. Muscle is the best way to lose fat. And most people, when they want to lose fat, they think of lowering their calories and doing cardio. They're trying to just burn. That's just kind of a recipe for disaster because you have to keep adding more cardio and adding more cardio and adding more cardio because your body adapts to that very quickly. But if you build muscle, you're burning more fat at rest. So yes, an hour on the treadmill or an hour of high intensity aerobic session will burn more calories than an hour of strength training. But if you're strength training, you're actually turning your body into a fat burning machine. And that's very, very important if you are in a caloric deficit. So if you're on a diet, when you lose weight, some of that's going to be muscle if you're not doing something about it. So, it's the best way to lose fat. And a lot of women say, I want to get toned, and we don't love that word, but tone just means you have muscle and it's showing. All right, perfect segue, because a lot of menopausal or even perimenopausal women, they want to lose fat. I'm postmenopausal, and Felice helped me a lot in that whole journey. But we're going to have hormonal shifts. Us women are complicated beings, and men have it very easy. So those hormonal shifts will accelerate muscle loss, bone loss. You're going to have hot flashes. You're going to have mood swings. And I'm not saying that strength training is going to get rid of all those things, but it can optimize those hormones and make those symptoms a lot less impactful in your daily life. I was having them, that's what I saw Felice, but in conjunction with functional medicine and strength training and exercise, I got through it. And then postmenopausal, sorry. It's essential for, just to repeat, it's essential for bone density, balance. We do, I think a lot of times when people do their own thing, in the gym, they do what we call bilateral movements, so it's two legs, two arms working together. We do a lot of unilateral steps, so one arm, one leg, and that really helps for balance. So, and then we're maintaining your independence. All right. GLP-1's and muscle. So for those of you who don't know what a GLP-1 is, it's the weight loss injections that are popular right now. And they're changing lives. We've seen it, with members in our gyms. But what people don't realize is if you're not strength training, it's rapid weight loss. And as I said before, when you lose weight, some of that's going to be muscle. If it's really quickly lost, up to 40% of your weight loss can come from lean muscle mass. So we're big proponents of not just looking at the number on the scale, getting a body fat test, seeing how your clothes fit, taking your measurements, that sort of thing. But without resistance training, you can, when you come off that drug, a lot of times your metabolism is slower because, again, the more muscle you have, the more fat you burn at rest. And I do have a story of, an unfortunate story of someone at our gym who was with us for years, strength trained, and needed to lose some weight for sure, and wasn't doing it on her own. So went on a GLP-1, unfortunately left the gym, came back months later. She was 70 pounds lighter on the scale, but her body fat was higher. So again, it's so important to strength train if you're taking one of those. No shame if you're taking one, but there's definitely some things you can do that. So one day, if you do want to go off of it, your metabolism is working for you. So again, it's not negotiable. All right, so you know what the problem is, you know our prescription. How the heck do we do it? What does strength training do?
Yes.
First, it's good to know that the media is catching up. We've never heard the strength training message in the past. But here's 3 recent headlines. Women should be strength training. It's the best anti-ager. It's a must to prevent falls. And this is awesome that it's out there. But again, what the heck does it look like? What should you be doing? All right, real strength training looks like, one, it takes into account progressive overload. And that's just a fancy way of saying you're progressing over time. So today you're lifting, X amount of weight, say for a round number, 100 pounds. You want to go to 105, 110, you want to progress over time. Or you're lifting 100 pounds for 5 repetitions today, and down the line you want to be able to do it for 7 repetitions, and so on. So you're tracking your progress, you're getting stronger, you're building muscle. It's planned and structured, it's not random. It's not just a class you pop into, lift some weights, and you do it every once in a while. We design 6-week training phases, all with a particular intent, and one workout builds on the next. So again, you're tracking your progress. There's rest between sets. Now this is a hard one for anyone who has done HIIT classes, high intensity. They don't want to rest between sets. They want to walk on the treadmill, or they have to feel like they're doing something. But that's where the magic happens. You're recovering. You're able to hit your next set with that same intensity, and recovery is essential for muscle growth and strength. There's controlled technique and an emphasis on form. I think, and you'll see in this next slide, a lot of people just want to get a lot of work done and feel like they did something and soreness is valued. But we want you to get through proper ranges of motion. So if you're squatting, you want to get your hips below your knees in a perfect world. If you're pressing overhead, you want that to be in a straight line. So, if you're not getting into the proper positions or progressing to get into the proper positions, you'll never get there. And getting into those proper ranges of motion actually builds mobility. I think a lot of people think of like stiff bodybuilders when they think of weightlifting, but it actually enhances your mobility. And then just a note that if you're new to this, working with a trainer is key. And it doesn't have to be there forever, but this is someone who can watch your technique, progress you, give you modifications so you don't get injured. Because the worst thing you could do is have an improper movement pattern and add a lot of weight to that, and that can just, add to an injury. All right, so this is what strength training does not look like. And I think this is where a lot of the confusion comes in, because every gym has a class that says strength bikes. This isn't anything local. I just grabbed this offline, the picture of these women, but they're probably moving for the sake of moving. They're trying to get that calorie burn. It's great if they're in a pool of sweat at the end of the workout. It's awesome if they're sore the next day. Just kind of like that. Fatigue is glorified. Many times they're using light weights and they're squeezing as many reps out as possible. So 3, 2, 1, go for a minute, get as many squats as you can. Because of that, there's usually no regard for form and technique. If you take a look at all of these women, not one of them is squatting correctly. So they're just reinforcing bad movement patterns and kind of wasting their time, to be honest. It looks like cardio with dumbbells. And just because you have weights in your hand does not mean you're strength training. Your body works on signals, and if your heart rate is spiked while you're lifting weights, your body's going to say, okay, we're doing cardio. And it's, you're not resting between cycles and all that stuff. So it's a lot slower than people think, and maybe not as exciting at first, but I tell people, getting stronger is fun. Tap your friend, rest between sets is fun. You can make it fun. All right, at this point, I'm going to bring my husband Rob up to the stage, and he's going to go over something he created, the quality of life circle.
All right, guys, so I'm going to talk about the quality of life circle, but basically with ours, movement patterns. And these are the movement patterns that we use every day in real life. So when you look at this quality of life circle, we call it that because the better you are, at least the stronger you are, the better quality of life you have. So when we look at it, it says a squat. It's basically the sit down, standing up. Then you have the hinge, and that's the ability to bend over and then pick something up from the ground. We have the lunge, so that's going backwards, forward, walking upstairs, walking downstairs. You have a pull, so that means you're able to pull yourself on top of something. You have a press, and that means and both of those are horizontal or vertical. And the press just means you're able to either push yourself up or put your dish up. And then a carry. And that's the ability to carry some groceries or whatever it is. So those are 6 fundamental movement patterns that we do every day in life. And everybody has to do them. And if you start to lose them, then we start to run into issues. So if you take a look, you'll see someone squatting with a kettlebell. It's a goblet squat. But as I'm moving through these, they're movement patterns. It's not a specific exercise. There's many ways to do it. So we're not married to an exercise. So then you have the squat. Now someone's there getting ready to pick their dog up and just pet it. You have a hinge, and now you see someone bending over to pick something up. You have a lunge, and now someone's walking upstairs. Then also there's a press, someone's putting their luggage up, putting something over their head. You have pull up, someone's pulling themselves up, and now they're pulling open a drawer. A carry, then you have a grocery bag they're carrying. So all these movement patterns are really important, they're the most important. Now you have your dynamic, moving, throwing, rotational, but without having these, those would be real difficult to do. So you want to concentrate on these and get yourself strong with them and with quality of movement. What happens if you start to lose that? So for instance, a squat. Now, I always say with that quality of life circle, if you start to have to regress it too much, then you need assistance. And if it goes too far and you lose too much, then you need someone to assist you. And that happens really quickly as we age. But there is a way to prevent it, and that is working on strength training. And then we have someone in the wheelchair and we know what happens with that. Yeah. So that's basically all she gave me.
I'm just going to go through three quick slides of kind of some case studies, success stories at our gym. I'll get through these really quickly. I know we're kind of going over a little bit. So, all right, first meet May. May's in the front row here. She just turned 71 years young, and she was always active. She was a tennis player. She came to us a couple of years ago, and her bone scans showed that she had osteopenia. So she started strength training with Zach, who's up at the front here, 2 days a week. Isn't it 2 days a week? Yep, 2 days a week. She even recruited her husband, you can kind of see behind her in there, Steve. But the point is, the numbers don't make a lot of sense to most people, but her lumbar spine improved by 30% and her hip by 13%. So she went from osteopenia, which is, on your way to osteoporosis if you don't do something about it, to normal bone density. And that was a recent scan, and everybody was like so happy. All right, meet Diane. She would be here tonight, but she's adventuring out in Kentucky, I believe. And she's actually a trainer at our gym, and she's gonna be 70 at the end of this year. She's always been strong. She's worked out her entire life, which is super fortunate. But unfortunately, she's had a couple open heart surgeries. She had a genetic disorder. So I think the first one was at age 48, 49, and then 7 years ago, so in her early 60s, she had the widowmaker, open heart surgery. So before she went into surgery, she was able to lift 232, she'll kill me if I don't remember that too, at the end, deadlift off the floor. So, barbell is loaded with weights, she safely picks it up from the floor, 232 pounds in her 60s. So she had an open heart surgery, recovered, was cleared to come back to the gym, and she was lifting probably about a third of that weight afterwards, and it was really difficult for her. So the question to ask yourself is, if you're not strong going into something like that, what's that going to look like after? If she was only able to pick up 30 pounds off the ground, which is kind of a heavy Amazon box, was she lifting 10, or does she need assistance from her husband, from nurses, things like that? So the point here is that being strong makes you very resilient. There's so many things in life that we don't account for. We get in a car accident, we fall, whatever, but the stronger you are, the more able you are to recover from those things that life throws at you. And lastly, Chuck, I think a lot of you probably know Chuck Sullivan. He's a lifelong athlete. So people look at him and they're like, oh, it's genetics, and he probably has good genetics, but he has never stopped working out. He really started with endurance, so Ironmans, marathons, things like that in his early 20s and 30s, but then he realized I need to strength train. So as he's gotten up in years, he's just turned 71 last month, he's really focused on strength training. And if he would have just stuck with endurance, he would not have the muscle and function that he has now. So excessive cardio pares down muscle, so it eats muscle away. So if you are an endurance athlete, it becomes really, really important to spend a couple days strength training. So now he just qualified for the Spartan Deca World event. His partner is 30 years younger than him, and he's keeping up with her. So it just shows how, really it adds to your vitality as you age. All right, last couple slides. The main word on this slide is prevention. So functional medicine and forward-thinking gyms need to collaborate. So people like Icaria, they help optimize the internal environment. So you're getting regular blood work, maybe you're doing some hormone replacement, peptides. They have lots of different technologies and interventions that you can work with. And we train the hardware. So we teach you how to move correctly. We help you build muscle, which in turn builds resilience. And really, prevention is a daily effort, and it's not a pill. And they touched on this too, that these pillars of sleep, stress reduction, exercise, nutrition are so important. And when you do want to have, get an intervention, whether it be a peptide or whatever, you're going to respond to it so much better if you have those other pillars really just nailed down. Last slide, just a little bit about us and helping people get strong since 2009. We know that gym intimidation is real, but we have a really awesome staff of trainers and members. They see somebody new in the gym, they say hi, they've been there before. We do group sessions, focus first and foremost on strength training, but it's a complete program, so we also do conditioning, and we do quite a bit of personal training, and that's everyone's first step in our gym. Even if you end up going to the groups, you'll start with some personal training. For those of you who don't know us, if you're interested in working with us, we have a little postcard. Just shoot us an email and we can get you started. And that's it. Yeah, there's just one thought to leave you with. Aging is inevitable, cannot change it, but living strong is a choice. All right, thank you. We're gonna take some questions, and Zach and Beth, who are both trainers from our gym, they're gonna come and get microphones. If you have a question, they'll come to you, and then we'll hopefully answer.